Hello, I'm Rachel and I'm doing my final project on systemic lupus erythematosus. SLE is a major rheumatic disease or autoimmune disease that can affect nearly any organ system. It may be classified in the articular inflammatory syndrome category. However, it has a wide range of systemic effects. It commonly affects the integumentary, musculoskeletal, renal system, respiratory, hematopoietic, cardiovascular, and nervous systems. There are 4 different subtypes of lupus, including SLE, which is the most common, discoid lupus, which affects primarily the skin. It doesn't have many more effects other than that. Drug-induced lupus, which is caused by certain drugs and usually subsides once those drugs have been discontinued, or a combination form of lupus, which is lupus in combination with some other rheumatic disorders, making the diagnosis of lupus even more difficult. The etiology of disease. Although the definitive cause of SLE is unknown, it is an autoimmune disease where the body attacks its own cells. It's characterized by the formation of autoantibodies and B-cell hyperreactivity. SLE is typically seen in females and has a 10-to-1 occurrence rate in comparison with males. It's most often diagnosed during the childbearing years. And there also seems to be a genetic component in the incidence of SLE, and twins are more commonly affected, meaning if one twin has it, the other one is likely to have it. SLE is also more prevalent in minority populations, including African Americans, Hispanics, and Asians. Although hormone imbalance is not a definitive cause, there's a high correlation between sex hormone imbalance, particularly estrogen, which is why women are more affected than men. And as previously discussed, we talked about environmental factors that could provoke lupus-like disorder. These could include medications, again, like we had previously discussed with drug-induced lupus, or other environmental factors such as UV light, chemicals, certain foods, and other infectious agents. Clinical manifestations of SLE. SLE is difficult to diagnose because it presents in a variety of different ways, and the cases are not typically similar across the board. Some patients may present with a butterfly rash, while others will not have a butterfly rash. Those who present with SLE typically, though again, it's not definitive, will express feelings of fatigue, malaise, fever, loss of appetite, and weight loss. Arthralgias and arthritis are very common, especially in the early manifestations of SLE. And SLE, because of these manifestations, SLE is often misdiagnosed as RA because of the arthritis. SLE is a more systemic condition than what RA is, which can cause anemia, pleuritis, pericarditis, glomerulonephritis, hematologic disorders, and seizures. There are other manifestations, as you can see in the picture over here, that SLE can manifest as. But one of the most unique characteristics, as I had mentioned before, is the butterfly rash over the face. Though it's not present in all cases, it is one of those manifestations that if you have it, you probably have lupus. So, diagnosing SLE. Because lupus can present itself in a variety of ways, as I previously mentioned, it's often difficult to diagnose. The American College of Rheumatology has defined 11 criteria to be considered for SLE, and 4 of them must be present in each individual in order to be diagnosed with lupus. So if someone presents with 4 of these following things, which I'm going to list, they have lupus. The criteria are as follows: a butterfly-shaped rash, raised red patches on the skin, light sensitivity, nose or mouth ulcers, arthritis in 2 or more joints, pleural effusion or pericarditis, seizures or other nerve problems, proteinuria, low blood cell counts, and certain antibodies in the blood, and a positive ANA test. So the ANA test, or the antinuclear antibody lab test, is not a definitive diagnosis for SLE. However, many people who have uncontrolled SLE have high ANA levels. Somebody can have a positive ANA test and not have SLE. They could have some other rheumatologic disorder, or they could just have a high ANA. So one of the better tests, one of the newer tests, is the anti-DNA antibody test, and this is more specific and geared towards SLE. So making a differential diagnosis. A differential diagnosis is confirming what you think you have as a diagnosis and eliminating other diagnoses that could potentially be associated with that. So one of the things that I had mentioned before is that SLE is often misdiagnosed as RA because of the early arthritic manifestations. Because SLE presents so similar to other rheumatic diseases, it's often difficult to diagnose. SLE is unique in that it oftentimes presents that butterfly rash that I showed you earlier in some of the slides, but it's not present in every case. So just because you have a butterfly rash doesn't mean that you have lupus. And again, you have to have at least 4 of the 11 defining criteria as stated by the American College of Rheumatology in order to be diagnosed with SLE. Further lab testing is often necessary, and those who have SLE often show evidence of other manifestations, including anemia, thrombocytopenia, leukocytosis, and leukopenia. Those who have SLE, again, will have like pericarditis and pleural effusions. Those who have rheumatoid, they tend to have more musculoskeletal manifestations as opposed to systemic ones, though they also have systemic disorders or systemic symptoms. They're just not quite as prevalent or as urgent. Other immunological testing may be done in order to further differentiate the diagnosis also. The prognosis of SLE. So gratefully, thanks to modern medicine, the prognosis for systemic lupus erythematosus has improved significantly. The main goal of treating SLE is to manage the acute and chronic symptoms of the disease. So the disease goes through periods of exacerbations and remissions. And as time goes on and the disease progresses, the exacerbations may progressively worsen. Initially, SLE is treated with NSAIDs to control fever, arthritis, and mild pleuritis. Unfortunately, due to NSAID use or chronic NSAID use, oftentimes GI manifestations may persist or may develop. And oftentimes, after using one NSAID for a prolonged period of time, they often become ineffective in treating pain and doing their job. So they often, secondarily, they use an antimalarial drug to treat the cutaneous and musculoskeletal manifestations of the disease. Thirdly, for acute or more significant symptoms of SLE, such as renal or CNS disorders, corticosteroids are used. And as a last resort for severe cases, immunosuppressive drugs are used. If the disease is not treated early enough, it oftentimes results in irreversible joint or organ damage, which can make living with the disease much more difficult. As I previously stated about drug-induced lupus, the following drugs can cause some form of lupus, such as hydralazine for hypertension, minocycline, which is an antibiotic, but it can also be used to treat rheumatoid arthritis as a DMARD, which I found kind of interesting. So one of the drugs that we would use to treat one of the most similar diseases can cause lupus. And the last drug that I found was procainamide, which is used to treat cardiac arrhythmias. So gratefully, with further testing, and if someone presents with 4 symptoms, they can be diagnosed with SLE and hopefully avoid use of these medications. And with time, hopefully their symptoms can continue to be managed.